All right. Hello, everyone, and welcome to another episode of the Biotensegrity Party series. Today, we've got something very special, episode 2 of Leonid Blyum's Everything I Know series, featuring interviews with Dr. Stephen M Levin, on how he came to find and why he came to find biotensegrity and his wonderful winding path on the way to it. Episode 1 was amazing. This one is entitled From Surgery to Something Better. So I'm Susan Lowell Desalorsino. I'm coming to you from Washington, D.C. Graham is here co-hosting.
I'm from Nottingham in the UK.
It's great to see you, Graham. And Leonid is co-hosting.
I guess so. So I'm in Limassol in Cyprus. So we are triangulating.
All right.
In a very flattish triangle, I would say.
Well, it's on a sphere. It's on a sphere. And
yeah, that's true. That's true.
Steve's here as well. Hi, Steve.
Hi. This is sort of like attending my own wake.
Come on, it's actually it's supposed to be a party with the friends, right? So it's not really that. So
so all right, I'm gonna just turn it right over to you, Leonid, and I'll start whenever you're ready.
Well, I guess according to our Tea Party tradition, I'm supposed to get some toast, but I think it's really easy, right? So you see, when we have the title From Surgery to Something Better, right? So you see, this is, I really like it. Actually, the title was given by Graham, and it was extracted from the meaning of this particular video. But I really think it's a very good kind of theme for the toast, because, when surgery is something, say, definite and something considered to be very proven, and then still having that kind of wide open horizons and looking for something better rather than sticking to kind of familiar, I guess that's a very good opening line for the toast. And that's why, for the continuous quest to something better. So that would be our opening toast.
Cheers.
Great. Cheers.
Cheers.
Okay, so I'm going to then just jump into share the screen, and we'll get this presentation started. And for those of you just coming in, it runs about an hour and 15 minutes. And then we'll have time afterwards to chat. Everybody can see it okay?
Mm-hmm.
Great.
Okay, so I'll mute myself as well. So just there would be a lot of me over there as well. So please. Dear friends, we are continuing our Everything I Know series with Dr. Stephen Levin. And you see, the first part, I think it was really fascinating. And there's a number of really good lessons that we can take right away. So, from personally, what I see here, the early history of the biomechanics, how it emerged and how it was really just an add-on to the original orthopedic experiences. Second point, which I find extremely interesting here, is the total, dive into the sort of essence of the orthopedic profession, even though the alignments and the conversation, which was pretty much going along the lines of being straight and so on, but if we zoom into the technical experience of it and into actually what is the sense of alignment, it was tensional. It's a tensional experience which goes a lot through the
connections and joints which don't have the easy alignment appreciation. It's not like really a straight column thing when we're discussing the repositioning and the fine-tuning of the things related, for example, to the wrist, right? So these are already great indications on what we are having in store, and of course, what I also want you to appreciate here, that we are talking about the 25 years of a fully fledged medical dedication and the orthopedic career that preceded the realization about the applicability of the tensegrity model. So between 1950, right? So when you just got to college as a pre-med, as a pre-med until your revelation day in front of the Snelson sculpture, right? So that's, well, shall I say that's a long period of time with a lot of experiences which were accumulated through. So
there were some questions I had in medical school that I only fell back on later. Like the book we used in anatomy was Grant's Method of Anatomy to guide us through the anatomy dissection. And in it he talks about things like the sacrum is falling out of the pelvis, and he points out that the lines of force through the arm are through tensional structures rather than compression structures.
Serious?
Serious.
So once again, that's the book. The name is?
It's Grant's Method of Anatomy. I have a copy of it here.
Okay, so we'll be able to find it.
And it's, I mean, he seriously talks about these tensional things, doesn't explain them, just brings it up.
Well, of course, we talk about 1950s, which probably the book was even from 1940s or 1930s.
My uncle was a physician who actually trained under Grant, who taught anatomy at the University of Toronto, and he was taking a class using the notes that eventually came to the book.
Oh wow!
So that's how far it goes.
But that was when 19.
Well, the book, I forget what edition I have, but in 1950. It was 1954 or so. Well,
and your uncle?
Yeah, my uncle was 10 years older than I am, so it was 10 years before that.
So he took it in 1940s, effectively.
Yeah.
Okay, so we're getting closer to the kind of covering the span of a century,
but
you know.
Those facts, those are right in the book, and left me with questions that I never had answered, and always stuck in the back of my mind because I remembered them afterwards when these concepts came up, and I said, well, my heavens, let me go back, because Grant talked about them in this book.
Wow. So that's one of the really peculiar things, how we tend to feel about everything as a sort of well-shaped and well-sorted and well kind of framed thing, but then there was like bits and pieces and the kind of loose ends that sit somewhere in their background or on as a kind of tailgate, but then they never catch the limelight, right? So that's fantastic. But this is actually quite a this is 11th edition.
Yeah, this is the 11th edition that my granddaughter had this in college.
Okay, this is 89, 11th edition, so that spans half a century effectively.
Right.
Wow.
So it's still being used because my granddaughter used this book, and I got a new copy because mine had fallen apart by this time.
Wow, interesting. Okay, so we are then. 70s, and well, let's continue our review of the scene. So but when you were doing those, the everyday practice and so on, so the mathematics of it and the biomechanics, they still stayed very much disjointed.
Yes, you just don't think about it. It's a clinical practice, and you're treating patients, and it's a physical interaction with the problem that you have. But you don't do the math on this stuff. It's just not part of what you do. And you don't think about loads on structures and things in the same way as you do. You just, mathematically. It just is not there. And experientially, it's not there. So that you do things that you, if you look at the math, would be absolutely impossible. You just assume that it doesn't make any difference. Then you always think there's another way around this that we don't understand.
So that's just the background feeling.
Yes, but there's no, and as I said, most orthopedic surgeons don't even spend the time to think about that.
That's
They don't
true.
worry about it. It's not part of what you're doing.
But did you have any, like it's quite a long period of time, but did you have any other, sort of, shall I say, candidates, right? So candidates to fill in this void and help you with the guidance, like any, architectural references, because also at the same time the technology was really, developing, let's put it like this, right? So you started before the man went to space, right? And then it was the man to space, and then it was the moon project, and then it was like a lot of things were happening in the 1960s in the scientific things, and well, Buckminster Fuller appeared on the cover of Time magazine, and like it was a lot of.
But that wasn't even in my consciousness at the time. I was just doing my thing. It really wasn't into the 70s when I started to specialize in back pain.
Okay, so in that respect, because I find it quite interesting, right? So the first applications of biomechanics, as we see from Frankel and Bersin, were focusing on the hip.
Yeah, a lot of it was on the hip.
So in that respect, they were not using the examples of the say foot or hand or whatever. So that's what they liked, and they were not the spinal people, right?
No, they weren't the spinal people.
But then came
Frankel had experience with Malcolmson, so he did spine stuff, but their main focus in their book and their teaching was the hip. Most of the teaching, if I remember, the course was mostly hip.
But let me ask you a few more things, because when we get back to the kinesiology in that sense, so you are saying that back in your training days, the kinesiology as such, that even like basic one-on-one course there wasn't really in
medical school, we never had a course called kinesiology. It was just sort of folded into other things we were doing.
So the kind of sub-part of, say, functional anatomy type of thing.
Right.
But the functional anatomy was also, did it have its own name, or it was just kind of...
We did anatomy dissection for a year. The only functional anatomy was if you're reading Grant's method of anatomy.
So
that's the only thing that had some functional anatomy.
So that was the only one which had the functional anatomy.
Yes, as far as I remember, that was a way of understanding what we were doing in anatomy, as opposed to just the anatomy. Because there's also Grant's Atlas of Anatomy, where you just do structure to structure, the atlas structure piece by piece.
So to guide you through the sections.
Right. Then there was also Frank Netter did a series of little books put out by SIBA, or one of the drug companies, that had anatomy things in it, and maybe a little bit of functional anatomy in it, but it was mostly anatomy, structural things that were very nice.
But let me ask you this, because you see, what we also experience is that when it comes to the biomechanics today, and with the discussion of the levers, right? So the favorite objects, or the favorite sort of choice of the illustration, would most often be the elbow joint or the knee joint, right? So that's kind of where you can draw the neatest diagrams and discuss the types of the levers and so on. So, but back then, in clinical practice, things like measuring the ranges of motion and this type of thing, how prevalent were they, and what kind of, say, integration your practice or the practice of your orthopedic colleagues had with the, say, with the say, functional anatomy via soft tissue people like physical therapy, for example?
Yeah, it was, for the most part, and still is, most of the time, the orthopedic surgeon is the technical person who fixes the structure, and the dynamics are turned over to somebody else. So they'll send you to physical therapy or a physical medicine person, a physiatrist, to get the body moving. But actual understanding of what the physical therapist does is very limited from the standpoint of the orthopedic surgeon.
Even though, again, in the chain of command, the orthopedic surgeon is kind of sits on top and supposed to guide and rule the physical therapist.
But their knowledge of that aspect of it is actually quite limited.
But
at least it was in my day, and it probably still is now, because what I see of people. In fact, it's even more specialized now because somebody is say a knee surgeon or a hip surgeon or an elbow surgeon or a shoulder surgeon. They're really specialized. Usually they get into the technical aspect of what they do, and then they have a therapy section of people who then do the rehabilitation. So the rehabilitation is almost separate from the surgical aspect of it.
But back in the 60s, within the orthopedic profession, there was much less specialization.
There was much less specialization.
So you were supposed to be doing everything from the toes to the shoulder.
That's right.
And the spine included.
Yes.
So, and that was a common practice there. So there wasn't like hard specialization, this is the knee and just the crucial ligament person.
No, very little of that. We just didn't neither had the skills or the tools to do it with. So we didn't have artificial joints, none of that. Except for this kind of hip prosthesis, we didn't really have anything.
Okay, but let's also kind of look at the scope a little bit larger, because as far as one looks through the medical history, so end of the 60s, beginning of the 70s, this is where the CAT scan and the MRI appeared.
Right.
And I would be really quite curious to know how that was, how that influenced and what was the thinking and the feeling at the time within the orthopedic surgeon profession through this kind of continuous education classes and so on that you took.
Okay, what happened? There's no dynamics in those pictures; they're just statics. And what happened is that pathology on the what's considered pathology on the specialized studies, the CAT scans, the finer X-rays, MRIs, pathology became the driving force behind everything. So it was that when a patient was seen, it was what was on this study that may correlate with their complaint, not a physical examination. So physical examination actually started losing out to what was on the X-ray studies. And it turned out that if you read the literature, even at the time, there was actually little correlation with some of those things. So that you could have an abnormal, say, MRI and no pain, or a normal MRI and lots of pain, or you had an abnormal MRI and pain and operated on whatever was on the MRI, and the patient would either get better or worse, and you look at the MRI and it would look exactly the same. And this is clearly in the literature, even at the time, and still is in the literature, that there's really little correlation with some of these things, with the exception of a herniated disc, which you can clearly find, but also has clearly clinical pictures that are more important than the physical findings, because you can have an abnormal MRI showing a herniated disc and the person be absolutely asymptomatic.
So when you talk about the clinical versus physical, clinical is the experience of the patient. Physical, you also include not just the physical examination, but particularly the shift towards the MRI and the instrumental, measuring things
representation. the measuring things that you could see became the driving force behind most of orthopedic surgery.
But that is actually a very interesting thing, right? Because the way that I understand it is that in the beginning, again, we talk about 50s and 60s, so with those kind of murky x-rays and whatever, so it was the physical examination, physical action, that was the clinical interaction with the patient, so those were the main things.
Right.
And due to the fact that the instrumental methods were rather basic, so
Certainly
they were
compared to
coupled,
today, yes.
they were just sort of additional items. Or well, it's interesting to see how to get your perspective on how this trend has changed and what was the driving force behind it. Like how come that, from being the addition to clinical reasoning, it became the whole thing has flipped. So now it's by now it's obviously the other way around.
When I was training in orthopedic surgery, the major diagnostic examination of the spine was a physical examination where you would have a complete examination of the person in movement, in several positions, and palpation, and neurologic examination, the whole thing. You would go through the whole thing.
So you were supposed to do the neurological examination as well.
We would do the neurological, we would do the physical examination. You do all that was part of it. We would do check for prostate cancers. We would do all that so we would do rectal examinations. You would do all this to examine the patient to see what the cause of their back pain was. Now, for the most part, you go into an orthopedic surgeon with a back pain, and they will not even see you without you walking in with the MRI in hand. And they rarely do a physical examination. If something shows up on the MRI, and you have back pain, you're going to get it operated. That thing that shows up. That's usually, I'm of course exaggerating a bit, but that's the tendency.
But when you lived through this tendency, what would be your just feel on the thing? Like, why did that happen? Why, the profession moved more and more towards this visualization instead of the experiential examination?
It's this driving force of technology. It looks, you see this on X-ray, and you have to believe it. It's the driving force of technology that makes you think that way.
So it's a very interesting thing, right? Because if we look at it that way, so what was your generation and the training and the practice? So when you are being experiential, we already understood that this is much more based on the tension and integration perception, right? So that would be your real clinical practice. But the moment things become more visual, then inevitably they start moving towards this kind of prefab maps and the alignments and all these things. So effectively they become much more formal in that sense, and they start getting, so the alignment from the tensional feel starts moving towards how it looks on the picture,
Right.
and and those forces and moment arms and so on, they suddenly start becoming much more, I'll say, it looks as if they become more practical, to say.
Yes. The whole concept has shifted to this technical diagnosis, and the technical, so the EMGs, the MRIs, the CAT scans, all those become much more important than the physical examination given by the doctor or whoever's doing the physical examination. In my day, when I first was in practice, it was the other way around, that it was much more important to do a decent physical examination because the technical things weren't as refined as they are now.
But interestingly, just I just want to get some feel there, so that among your profession, so people, did they welcome and say, hey, finally we get, now we don't have to think, now we don't have to feel, now we can see, or it was met with a certain resistance and like, so how was it, internally?
It was never met with resistance. Back pain has always been a mystery in the profession. And once somebody can come up and say, oh, look at this is why they are hurting, then everybody would jump on it. So it was because of the mystery surrounding back pain, and it still surrounds back pain, but the mystery surrounding it, that as soon as somebody could come up and show you something that, oh, we could say this is a cause, then you would accept it. And this was what happened. So degenerative spine disease, all these kind of things all of a sudden have taken over because he can see the picture.
So seeing is believing.
Right.
That's really, especially at first it felt like eliminating opacity and leading you in the right direction. So that was, so was there a certain sense of excitement within the profession?
Oh,
when these things...
Oh, the MRI was it. But you have to understand, again, when you live long enough, you go through a lot of things. So they must be up to their 15th or maybe 20th generation of MRIs now. The first generation of MRIs came out and they said, oh, look at this, what we could see and all that sort of thing. Then the second generation came out and says, we could hardly see anything on the first generation. We really could see stuff now. And and so on with every generation. So as they refine the MRI and the studies, they see more and more, and they blame more and more on these little blips and little changes because they may not understand it. And since they're not doing physical examinations anymore so much, then they just accept what they see on the picture.
But the MRI, the first clinical. Your first experiences with MRIs and CAT scans, when did it first happen?
I don't remember when they first came out, but it must have been in the 80s, I guess.
It's in the 80s?
Yeah, I believe they started in the 80s.
So, because I think that the first experimental machines appeared like in 1970s, but it wasn't until 80s that they actually became
clinically relevant and available. More widely available.
Okay, so it was another 10 years before they became the...
I believe so, somewhere in there, that were really came into use. And as I said, and about that time, said, we got a picture, but you don't need to bother with all the examination. So they stopped doing examinations.
So that has been transitioned around the 70s and 80s, effectively.
We used to do myelograms, where you inject dye into the spinal column and see the changes and things like that, but you're only looking at this canal and you're looking for bulges at the discs and things. But the MRI became much more refined, and again with each generation even better, so that now we see little blips and things, and since we've established what is standard norm, so everything that deviates from that standard is bad, as far as it's considered bad. So
that's the logic, and effectively that. So may I say that if we look at 60s and 70s even, so the understanding or the visual representation of the norm wasn't very well established. So it was just a very general thing. So things have to be kind of straight and so.
Yeah, you could get some good X-rays, and they would tell you some things, but you're only taking shadows of structures inside a lot of soft tissue, and you're only taking a front view and a side view, and so you don't see a full three-dimensional kind of concept. And when CAT scans came in and then MRIs came in, you saw this as a three-dimensional thing. And you see, even MRIs are not X-rays. And yet when it's given to the doctor to see, it's given to us as if it were an X-ray, because we are accustomed to seeing X-rays. So they show you these things that make them look like X-rays when they're not at all. So it's part of this whole psychological thing of how you're approaching this thing. So since doctors were used to looking at X-rays, they showed you an MRI, and now we got a three-dimensional X-ray.
Mm-hmm.
You see, so all of a sudden, we're talked into well, this is abnormal. So there it is. And the radiologist, who isn't a clinician most of the time, may never see a patient.
Yeah, which is the case.
Will look at this and say, oh, well, this is not, he's giving a book that shows normal, and this is not normal. So.
And this is where
that's all he knows.
So, and that's where the artificial intelligence is supposed to come in and start getting even more of those, right? So,
I'm not blaming anybody, except you have to understand the technology, and of course, now, I will tell you, my clinical practice, towards the end of my clinical practice, and because we're jumping years now, but at the end of my clinical practice, I was just doing non-surgical back pain. I was already in my late 60s. I said I didn't know surgery anymore. So I was doing non-surgical back pain. And people would come in my office carrying armloads of X-ray studies and MRIs and all that. And I would not even look at them because I already knew that the other doctors had looked at them and decided they weren't going to operate on them, or vice versa. And I would do a clinical examination, and these people would say, well, nobody ever got me undressed before, nobody ever examined me before, they just looked at these pictures. And some of them were very upset that I didn't look at the pictures. I got thousands of dollars worth of studies here, and you're not even paying attention. Well, I already knew that there was anything there anyway, and even what was there wasn't relevant to what was going on.
well, this is really a brilliant piece here, right? I really want to concentrate on this, because you see, this is the quality of thinking which is really, really unusual in this profession. Like I would say that this is beautifully mathematical, right? So you see, if a person comes with a truckload or armload, a truckload of X-rays, so this is really thinking by exclusion, meaning that if the other, they're not coming to you as the first point of reference, they're not coming from the street, so that means that somebody else experienced and so on already went through, and if there was something of clinical relevance, they would have grabbed them much earlier.
Right.
So, and they would have acted upon this pathology. So in that respect, your algorithm would be saving the time and saying, hey, if there were anomalies, somebody else would have picked up on them,
right.
If there was something dramatic. So I actually have the full capacity to get back to the clinical examination and see what would be the finer aspects of it, which are actually beyond the X-ray, right?
Right, which are dynamic, which you don't see in an X-ray.
Okay.
It was a dynamic, I was interested in the dynamics of the problem rather than what was on the picture. So, and it usually wasn't one doctor before me, it was usually 3 or 4 or more doctors before me, that these people have gone through a series of people, and they've all rejected them.
Okay, but let's get back to our chronology, and right. So we sort of ended up there when by the late 60s and the early 70s you acquired a greater interest in the spine.
All right. Well,
what was the driving force behind it, and how that all happened?
The driving force behind it was specialization was moving into orthopedics. You were getting hand surgeons, and then hip surgeons, and knee surgeons, and spine surgeons. So it was becoming, a specialization.
So you kind of had to choose.
You were sort of pushed into. There's still some general orthopedics around, but most of it, people were being pushed into specialty.
But were you in your personal, private practice, or you were in the hospital?
Well, you have to understand that the half-life of any surgical procedure is about 5 years, and it's faster now. So that means that every 5 years, what you learned 5 years ago is no longer good. You've got to have something out. So you always have to work hard just to keep up with the newer techniques and the new equipment coming in. If you were doing it in knee surgery and shoulder surgery and hip surgery and spine surgery, you would spend all your time going to these courses, and you would have nothing else but courses. So the onslaught of information forced you into a narrower path of work.
So you were saying that the half-life of the orthopedic procedure is about 5 years.
Right.
So, and that's why once the specialization went in, you had to, if you wanted to keep the general specialty, so you shoulder, knee, spine, and so on, then you would just spend enormous time on
Taking new courses, because in medicine you're always keeping up and taking new courses and finding new information. So and things are changing. As I said, every 5 years the particular profession changes. So you would have to spend all your time learning new techniques, and it's impossible to keep up with all of these things and to have enough cases of a particular type to keep the skill in the particular mechanical things, new skill that you learn. So the force of it was just to channel everybody into a particular specialty. So at that time, I actually had done a little hand surgery, and then I was in knee surgery, doing a lot of knee surgery, and then I said, well, I want to focus on spine surgery.
But what was the reason behind this choice? Okay, you had to specialize, but you had something particular interest in the spine?
Yeah, I had interest in the spine, but it wasn't, there were not, I felt there were enough hip surgeons around and enough knee surgeons around, and hand surgery was another specialty that took a lot of time, so I said, I could do spine surgery, because I was already doing it. I had an interest in spine, so I sort of was focusing a little bit in that direction.
So in that sense, it wasn't like a very strong...
No, it wasn't that kind of thing that I was always born to be a spine surgeon.
Okay.
It was a specialty that I was comfortable in and wanted to pursue. But it wasn't, as I said, I preferred being a general surgeon, a general orthopedic surgeon. To me, it was more fun to do different things.
Mm-hmm. But okay, and then how? Okay, so you were kind of channeled into this by the shifting landscape,
right?
So, and what were the interesting things, and what was your learning curve, and what were the interesting things that you actually kind of got an experience there?
Well, I was doing spine surgery, but going back to that. The graduate year at the University of Pennsylvania, I had worked, as I said, with John Manel, who was taught me manual medicine. So people would come in, I would see people with back pain and feel they were not good surgical candidates, but would treat them with the manual therapy. And lo and behold, I was getting better results with manual therapy than I ever did with surgery. So I said, well, geez, I got to understand more of this. So I went and actually retrained with John Manel, spend more time with him, but also then started looking more into the biomechanics of the spine.
Okay, so that was actually the interesting thing. So if we look at it from the whole kind of collection of sort of episodes and I would say serendipities. So the entire experience, the original experience with John Manel was very much a serendipity.
Yes, absolutely.
So you were doing the course in Pennsylvania anyway, and he just happened, like some obscure English manual medical practitioner has been there, and the whole premise was that he was going to improve your diagnostic skills.
Right.
So imagine it was 10 years later when the MRI would really come in, nobody would even bother about it, right?
Right.
So because then
Right.
you would probably you would have.
But I had developed these diagnostic skills that he taught me because I spent a lot of time, elective time in his clinic.
Yeah, but this is really interesting in a way how this kind of the opportunity shapes there, right? We talk about the end of 60s,
Right.
or I mean the mid 60s there, when it was just pre-MRI,
Right.
sort of, or
Right.
pre-big leap in the
Right.
improvement of the X-rays and so on, pre this in shift towards the visual,
Right.
so that the person who was actually supervising your graduate training there, so he said, hey guys, you know, go there and get some improvement in your
Diagnostic skills.
diagnostic skills, meaning
Right.
the physical,
Right.
the physical examination
Right.
skills,
Right.
which just
was-
10 years later, that was a
which
dying
was-
skill.
Which exactly was John Manel's. That was the key to his work, was a physical diagnosis, and then you did his therapy. It was very selective. You only did the procedure he described if you found these particular findings. So it was a diagnostic process, a physical diagnostic process.
Just since we're on this, the interesting thing here is again, so, but when we get to the diagnostic process as a part of the physical examination there, was it more sort of algorithmic in terms of, okay, you feel this, or you feel this? So was it more algorithmic in that sense and more based in the experiential field, or was it more like a calculated biomechanics? Like how much of the biomechanics was there?
It was a field thing.
So biomechanics was not really there.
No, nobody talked about biomechanics.
So
John Manel wouldn't know which end of a screwdriver to hold.
okay. So that's really interesting as well. So it was a spine included,
Oh yeah, a lot of it was spine.
but nonetheless there was no biomechanics per se
No.
in terms of the like calculations
No.
or angles or whatever.
None of that.
So there was no real talk about angles.
None of that. It was all physical diagnosis related to movement patterns.
So, and again, an interesting thing is probably because of your prior wrestling experience. So you've been more equipped and to take on this particular route than your, say,
Right.
colleagues.
Let's go, just to bring you back to wrestling.
Okay.
When you're wrestling and you're holding on to somebody, you know their movement before they make their movement, because you can feel the way their muscles respond and things. So you are actually, by feeling what they're doing, anticipating their move to make a counter move. So it is a very experiential thing, and yes, it's very tactile, and it is very
Kinesthetic, I would say. Like
Kinesthetic,
on
yes.
not
Yes.
just a tactile
No,
2D, it's a
kinesthetic.
3D
It's a
kinesthetic.
kinesthetic concept that you know.
And then, but you see, if we kind of get back there, so it's 3D kinesthetic, right?
Right.
So it has the ground reaction and redistribution into it,
Right.
right? It has the total chain
Right,
through the entire body, right? That's really what we had to toes.
right,
And it has this, effectively, that's where we're working with the closed kinematic chains.
right. So when I go back to John Manel, this was a skill I was very comfortable with, because that's what I did when I was in college, in wrestling. You see, I would feel these things, and he would say, well, feel this, and I'd feel that. And other people, he would say that to other people, and they couldn't feel it. But I could feel it because I had already been trained when I was a wrestler to feel that kind of subtle movement.
Fantastic. So, but in fact, we can say that when we talk about the subtle movement, we actually talk about even pre-movement.
Yeah,
So it's even precedes. If we were to take a snapshot of that, we wouldn't be able to see it actually.
right,
So it's this kind of 3D experience that happens, again, tensionally, within the co-joint system between two wrestlers,
right,
which happens prior to a move, and that happens at the pre-movement phase. So even the series of snapshots or the snapshot taken before that move wouldn't be able to detect it.
right.
So that's a very interesting thing, right? So that it actually gives us the whole, like the underwater part of the iceberg, to say so. So what's happening there, where the movement itself, the visible, like elegant wrestling move, or the winning, your record 4-2 and 1 in the 1950.
That was before that was better. that was my bad year.
Well, you didn't keep that particular program, so we had to deal with this. But still, it was a winning record,
Right.
So okay, I see. But which was the weight category that you were in?
123 or 130.
123 pounds.
Yeah, it's a long time ago.
Okay, so let's now get back. So in fact, that means that you moved back into the spine, and well, I should then bring another point, is that which probably essential here, is that for an orthopedic surgeon, if you compare the monetary value of a surgery versus the manual intervention, is there a difference there?
Quite a bit.
Quite a bit in favor of what?
Certainly of the surgery.
So in that respect, you were kind of, from a monetary perspective, you were sort of shooting yourself in the foot.
I guess so. Yeah.
You guess so. But I would understand that, that this is also the factor that people that to a great extent becomes the driving force, right? So you have to have enough of the curiosity and enough of this sort of original physical examination or physical connection to a patient, say, hey, why would I do the big thing whilst I first, even if it's more rewarding to me financially, but and kind of actually draws greater respect, right? So you see, because surgery draws a lot more respect than just kind of minor fiddling move. Or it doesn't hurt. What is it? Maybe it was an accident. Maybe it was there, but the surgery, something serious, right? You've done it. You feel yourself proud. You give yourself a medal, right? So that is an interesting combination of the events as well. So in fact, your manual part came as a sort of subset of what was fundamentally meant to be a surgical career.
Yes.
So it just happened like this. So
just happened. No planning at all.
No planning, and that's when you started to get interested into the explanation. So it was experiential first.
Yeah.
Whether it was the training with John Minnell, whether it was the physical examination, whether it was like this success of those micro interventions as opposed to the macro interventions, which actually led you to the question, okay, now I'm trying to figure out what is the bigger picture behind it.
Yes.
So in fact, we're talking that this has been like what, at least 15 years into your medical career when this type of questions really started to get some feel, some, sense of maybe urgency and the true curiosity of how to expand your understanding.
Yes, I would say so.
That's, that's a lot of experiences.
Yeah.
And where did you start looking at? What was your first sort of scope of probing and figuring and trying to figure things out?
Well, I actually went back to some of my college books.
Interesting.
Yeah, and I told you I had physics. One of my professor there was a fellow named Henry Seamat, who wrote the textbook, and I had his textbook, and I went back to look at some of that structural things in there. And then so I started working on that. Then I started looking into the architecture books. And there used to be a bookstore in the basement of the Smithsonian, and it had an architecture section. So I went and I started looking at the architecture sections. And then I started delving into some of these things.
And okay, so when you started looking into the architecture, so what were the trends at the time, and what were the things that were catching your interest at that point?
Well, what I quickly understood, I was looking for something that was stable. You see, because I didn't see the body as collapsing all the time. I saw it as a stable structure,
Inherently.
inherently stable. You know, that to me it was stable. So I said, how do you, and again, I also got into the energy concept of, you know, how much energy you need to do things. So,
Okay, but that's a different concept. That requires a different set of books.
well, maybe, but it still is. It's a concept of, you know, how do I hold things together without, you know, with the least amount of energy? And you start reading things like even Seabat's book and things, you know, to stay in triangles. So you start.
Okay, so I think that's a very important part here. So I think that we really have to highlight this, is that because it's a lot of it goes from the original feel. What kind of the big feel you want to kind of to satisfy for yourself? Because if it's, you see, the way I see it is that if it's a sensation of the permanently sort of fall, the body which is having a underpinning tendency of falling apart, like getting to the flaws and so on, and then whatever, by virtue of some strange circumstance, just happen to be held together, that's one feel, right? And on the other hand, when you feel that it has to be experientially, you experience the robustness, which is one of the things which you probably would be surprised many times, like how robust people would feel, right? Am I correct on that?
Yes.
So you see that sense of robustness and in fact the resistance to failure. So then you start looking for, you know, then you kind of, when you're scoping the body of knowledge, you're being drawn to different manifestations there, right? And that's what I find very interesting here, that if we look at this, so it's a Biotensegrity day, right?
Yeah.
So that what I find very interesting there is what you just mentioned, is that that has been in conjunction with the idea of the minimal energy principle. So in that sense, minimal energy principle and the principle of sort of sustainable robustness, they came for you as the precursors of actually finding the embodiment.
Yes.
So I'm correct on that.
Yes.
So I think that this is really important to bring it, because, you know, again, as we are now, we are like 45 years post tensegrity revelation idea, or like, you know, the feel that it was the suggested embodiment of it, right? But I think it's really essential that we go back to this and say, hey guys, you know, it's not that we are so hung up on the tensegrity as such, right?
No, I didn't start with tensegrity at all. I started with how can I make this body stable and not collapsing with the least amount of energy. I mean, that's where it was. It had nothing to do with tensegrity. I didn't know tensegrity. Never heard the word. So that's not where I started at all. I started in how do I get a structure that's stable.
So, and that's why you went back to the college books, you know, and that's where you started looking at the stabilization.
If I remember, there's a picture in Seabat's book that's a truss bridge showing, you know, of the forces going through a truss bridge kind of thing.
Mm-hmm.
You know, with arms and pin joints, and they're stable. I said, well, there we got a model maybe.
So that was the first thinking, the first sort of, say, physics or mechanics reference that you felt was sort of, you know, at least resonated better.
Yes.
So it wasn't through calculations or whatever. It was just like, okay, this thing seems inherently more sort of in line with what I'm looking at.
Yes.
So rather than just those strange, well, like the huge numbers that you were hearing, let's say, 8 to 10 years prior, right? So you see, if we kind of put into perspective, beginning of the 70s, mid 60s, so something like this, right?
You look at the thing, I probably can find it in the book. It's a picture of a trussel kind of bridge and showing the force lines as it goes through what goes compression and what becomes tension. You know,
The dualism there.
yeah, and it, you know, and it goes up against it and it shows you lever force when you attach it to the wall, but through the system it's tension and compression. And I said, there it is. You know, I'm sure that was my driving force behind it. But then problem was to find a truss, you know, in 3 dimensions that would also be omnidirectional. So I started looking at
Architecture.
yeah, I started looking at the architecture and then the construction cranes. To me, the construction cranes were it, you know,
Okay.
because I could see these big long arms going out and all this kind of thing, and it's all triangulated, and it's a narrow column, and it's pretty stable and all that sort of thing. But I couldn't figure out how to turn it upside down and right side up.
But okay, let's get there. So you started. So I guess at the time there were a lot of construction going.
Okay, yeah.
That was
Construction all over Washington, there was construction cranes.
Yeah, that was like Beltway time, and then
Yeah, there were, you know, there was these tall construction cranes. Every time they put any building up, it became these tall construction cranes, which were relatively narrow thing, and you know, this big long arm on the top. I said, well, geez, this is a great example for it. So I started looking at those things.
But did you, at that point, did you sort of have a feel for some clinical correlation of that? So no, that was just a model in that.
That was a model, and then I went and I spent a lot of time at the Smithsonian looking at the creatures down there.
Oh, but that's a different angle from architecture. So let's.
No, it wasn't. I was moving. I was moving both at the same time because I told you the architecture section was in the basement of the Smithsonian at the time. There was a bookstore, so I go to there and I look at the
architecture.
The architecture, and I go there and look at the skeletons and I try to figure out what was going on.
Okay,
so I was
that's
playing that game.
Okay, so that's another kind of serendipity there. So
yeah, it was.
So in that respect, the architecture bookstore could have happened, you know, like a mile away.
Right. No, it was right. It was in the Smithsonian. So I was looking at, you know, I look at the models and I look at the thing and I try to say, it doesn't work, you know. And I kept saying, you know, there's no way that this creature can be walking on those toes, you know, at this
You're talking about the dinosaur.
Yeah, there's no way you can have it next.
But when did they put the dinosaur skeleton there?
Oh, that's been there. Well, it's back again, but it was there for years. It was there as long as I remember.
Ah, so it wasn't a recent thing there.
Oh no.
But just a kind of curiosity question there. So if we look at the sort of heyday of Buckminster Fuller, that was 1960s, right? So you see, that's where he was. You know, I think a couple of times he was on the Times Magazine. That's when he published most of his, you know, like the Spaceship Earth and all these books. And you know, that's when he designed 1967. He designed this the geodesic dome for Montreal Expo, but
that was not part of my picture at all.
So you haven't caught an eye on neither of.
None of that was in my understanding.
Even if you kind of saw in Washington Post.
I had seen.
You have seen it. You have.
I've seen geodesic domes and things like that, but it had no. I didn't even. It wasn't in my consciousness. 1974, they put up that tower, the Needle Tower, and I went down. You know, when that was the Hirschhorn open, and I went down there and saw the tower, and I said, it wasn't particularly there. It was just I saw the Hirschhorn. I was fascinated by the thing, but I had no idea what the hell it was.
Okay, so but this poster is not from 1974. That's from later.
No.
But that's when they put it.
Yeah, it went up in 74.
Okay.
The Hirschhorn opened in 74. I went there, but I had no idea, no relationship to it at all.
Okay, so you saw it, but then it's just kind of.
It was a piece there, you know. I fascinated me. I couldn't understand how it would stay there and all that sort of thing. And since I was looking at architecture, thinking, you know, it interests me, but I didn't think about it anymore, you know. But it was then I started looking at all these cranes and all these kinds of things, and I was having problem with how to. that I understood the forces in the triangle. Again, I'm going back to CMAT's book. Understood the forces in the triangle, and you push on the top, and you have compression here and then tension on the bottom. But how can you turn it over? And I knew the body had to turn over. And I said, how do you do that? I couldn't get it. I'm looking for a omnidirectional, what is technically known as a space truss, a three-dimensional truss. And I couldn't figure it out. So I was in the museum, and I'm going over this over and over again. And
but was it sort of a curiosity thing, which at that point didn't really, it's...
It was more curiosity. It had nothing. There was no direct relationship to what I was doing physically.
Mm-hmm.
It was more a curiosity of understanding what I was doing, why I, what kind of things I was doing to the spine. But there was no. It didn't. It just like before. There's no connect between the structure and the spine directly because I'm treating somebody and it works. That's it.
Okay.
I'm happy with it's a mechanical thing. You push this button and it works. That's all I care about. But intellectually, I wanted to know what the hell I was doing. So then I started.
But just then, let's take a detour there. But at the same time, you took those continuous education courses with all the leading figures of the time. And
that's part of the curiosity thing.
Okay, so what?
Like that thing on a workbook or something. It had nothing to do with actually taking care of somebody. It was because I'm intellectually curious about all this stuff.
Okay, but when you attended those courses and which were held by the leading spine specialists of the time, did you first feel that they were asking the same questions? Did you feel that they were giving you accidentally some answers, or how did that feel?
There was a disconnect between what they're describing from the standpoint of mathematics and what I was doing with the patient. There wasn't any question in my mind. And also, since I had this manual medicine kind of thing, they would describe things that didn't make any sense to me as a total body thing. Well, they're describing this is happening at this level with this kind of thing going, and I say, well, hey, wait a minute, you have to understand that this is much more complicated than that, because when I'm doing a spine here, there's an interaction in the whole body that I can feel and understand that the patient talks about, so I can do something. So when somebody's got a back pain, there may be also a problem in the foot I have to know about.
Mm-hmm.
That they don't even connect at all in any way. They're still doing the math of this thing and that thing broken and the pressure on the disc and all this sort of thing. To me, they're too local, and I was thinking, by that time I was thinking in, global.
Mm-hmm.
That this is a global problem, and yet, with something stuck in the middle.
But these people at the time, they were quite excited about their findings. So that was the first.
Yeah.
Those were the first kind of years when the calculations became more extensive.
Once Nathanson came in with these precious, a measurement thing, that became very important, the measurement thing. How much load was there and all that sort of thing.
So to measure the intradiscal pressures.
Right. Once he came in with that I knew it was wrong.
But they only measured the intradiscal pressures in the labs. They didn't do it to the patients.
You're right. It was on patients. I mean, in the lab, but with some people going from sitting to standing, bending over a little bit, and it was a very limited number of people. Sometimes they would publish a paper based on 4 people.
Yeah, because it's quite a cruel thing to do,
Yeah, I wouldn't have somebody do it to me, I'll tell you. So they would sometimes write a whole paper based on four patients or 4 subjects that they tested with this kind of thing. Well, let's see. I said, first of all, what is for? And again, I could say, wait a minute, tires don't work that way. They got it wrong, and I knew that right from the beginning. They got it wrong. And again, this is simple physics. Pneumatic things are different.
Okay, but when you would ask this during the class, what kind of answer would you get?
It was a pat on the head. Well, if you were an engineer, you would know better. You would understand what we're talking about.
That's it.
That's it.
So, we respect you, doctor, but don't,
you stick to what you do clinically. We give you the explanation here.
Okay, so it was a bit, in that sense, it became this kind of, it's this patronizing type of thing.
Very.
So that you guys, you are the carpenters, we are.
Yeah. One engineer once told me, he says, son, and I was already 5 years older than he was, son, you have to spend 5 years in engineering school before you understand what we're talking about. So I went back and I got calculus for dummies and all these kind of things. I did all that stuff, and I looked at it and I said, they're all wrong. And I went back to doing what I was doing.
Okay, so you even started looking at the calculus at the time.
Oh yeah, I got it. I got one. This around here someplace. Calculus for dummies. Or
well, I mean, they were probably there were nicer names back then.
Right.
So.
Right. But really, I went back and I did, we did the calculus and all that sort of thing. And I said, hey, wait a minute, inappropriate. Doesn't work for me. Doesn't work on what I'm doing.
Okay, but that was really based on the strong sense that it didn't fit, so that you had a strong sense, so you were unfazed by the fancy numbers.
Right. Once I understood that it was a truss system, which became very obvious very early, when I started thinking, then the search was finding a truss system that worked.
Mm-hmm.
That was the driving thing behind me, and it was very difficult to find because I couldn't find one that I could turn upside down.
Okay, but let's get further for the listeners. So the truss system, so why do you feel, what actually, let's sort of summarize, what attracted you so much in the truss system, and well, what are the key elements that you felt were the essential?
Right. What truss does is separate the compression and the tension into component parts, and so the hinges, the joints, don't have any torque around them. So I said, gee, how much better can you get than that?
Okay, so these were the key points, right?
So I could see the ligaments and muscles in the soft tissue, and I could see the bonus compression elements, and I could see that the joints could sit there without. I had frictionless joints I'm dealing with in the body. I knew that. I said, so I could see, well, we can stabilize those joints if we triangulate it. We don't have to make a big fuss about it. So I was then looking for triangles in the body, of course.
Okay, so it was a triangulated perception.
Yeah, it was a triangle. It was
triangulated perception. So you really like the fact that there were pin joints, which kind of makes a clinical sort of, the body correlation, right?
Right.
So if we think about the, especially with the obvious things with the peripheral joints, right?
Right.
So, but the other part was that the truss does that separation.
Right.
So that the compression and tension, they are being split into the components.
Right. Now, I didn't look for that at first, but it became obvious when I saw it that was an advantage.
Okay, but now, at that point, so when you had these conversations about the, so did you speak about the trusses to those?
Oh, yeah.
And what was their response?
No, they said, no, it can't be.
And they can't be why?
Well, they don't, there's no reason. They are the professors. They know better. These are engineer people. Engineering is you deconstruct everything, you take it apart, and you reverse engineer it.
Okay,
But that's what they were doing.
Okay, but let's put it like this. So the Trussen is an engineering system in the first place as well.
Yeah, but they don't deal with it.
So for whatever reason,
They completely ignored it.
so that was just it. So you see, but what was the reason? Whether it was more difficult to calculate, whether it was so, it was no specific answer.
I don't think so. I just don't think that they physically saw the truss in the body.
That is simple as that.
I think so. They couldn't see a triangle, so to them
They
the bones
couldn't.
were-
Okay, so they couldn't see a physical triangle.
Right.
So and that was minded. That was before the mesh, before this kind of the fine element analysis
Right,
meshes
right.
appeared. So
Right.
that was really because now we're sort of all familiarized with
Right.
this like multiple triangulation, right?
Right, right.
But back then,
In those days, the cover of the Journal of Biomechanics was all cubic. It had a model of something, a spine or a hip or something or other, but it was the squares, not the triangles.
even
I'll find a copy for you. I'm telling you, it was the standard. They had the same copy cover over all the time, and it was a cube things. It was squares. There's no triangles.
I see. So in that respect, something that could be as little as that is just kind of the preference towards the cubes as the elementary building blocks or
Right.
whatever the way the elements on which to base their stacking.
Right.
So
It
that
was a cubic concept that they were building things from blocks, from the bottom up.
But do you have, just if we get a bit of a time travel now, because obviously the last, 15 years at least, we have a lot of this mesh and the analysis and so on. So by right, one would think that at least the triangulated sort of sensation or the triangulated perception should be, like kind of more welcome, or at least find the independent way. I'm not talking about
Right.
the biotensegrity
Right.
now. I'm just talking about the triangulated perception,
Right.
finding it's the independent way into the, like at least as the alternative sort of concept there. So you rest your case. It's hard to say why.
Hard to say, wait, there are easily observable closed kinematic chains in the body that is obviously there, and for some reason or other you still do the math as if they don't exist. You can't do reverse engineering with closed kinematic chains. Reverse engineering, inverse dynamics requires you from the lever system, from the bottom up. And there are all these closed that are obvious. They show them on the pictures. They even say it in the thing, and then they ignore it and still treat it as if they're not.
Well, I mean, basically,
So,
they're being seen as the sort of, as the aggregates of the elementary parts.
Right, but that's what it is. But they do, so they don't see the triangles either. They're worried. They are fixed on this cubic system, and then and then since in the cubic system, each thing works individually. You get torque at the joints, and all that, and they're stuck with it, and they still do that.
Okay, so that's where we return to the fact that you were the click without that there was no torque at the frictionless pin joints. There was no torque. That's the part that had a special resonance on you.
Yeah.
So that was a big point.
Yes, that was a big point.
Okay, so
I suddenly recognized stability to me there was stability there.
stability rather than falling apart,
Right,
rather than the
right.
tendency to fall apart at
Right.
any moment in time. So
Right.
the system which was inherently self-stabilizing as opposed to the system which is inherently unstable and require the continuous, control circuits to deal with this.
With big forces.
And with big forces. So okay, that was before the control circuits. It was the big So it's the big forces that you did. Okay, I see. So it was the big forces which sounded the most outrageous.
Hey, when you're in there operating and playing around with muscles, they are mush. When you poke at articular cartilage, it's like the density of a boiled egg white. I mean, it shears and breaks off easily. You can poke at the end of the long bones, and you can actually just jam a curette right through them. They're soft. And these people, muscles you could just separate like this and pull them apart. And these people are telling me they're taking, hundreds of pounds of forces. I mean, it just doesn't make any sense. As a clinician, you know better.
But let's get like this. But just as a kind of side note.
Right.
But for instance, when you see certain elements like contractures and so on. So what is their physical experience? Because at least that's where you read the account of the orthopedic surgeons speaking of the accounts or speaking of the contractures being like tethers and super stiff and so on.
Right.
So that's true in that respect, but that's kind of an offshoot.
Yeah, it's an offshoot. Yeah, if you have to understand the normal before you can understand the abnormal.
Okay, so that's that in
Right.
that particular line. Okay, so that if we really put it on the experiential level, like what was the most kind of the bell ringing, that's this mismatch.
Yeah, the forces. You're right.
So this dramatic because I see it in you, like when you I can see that you really change in total posture when you see those like 800 newtons or whatever at the acting at the spinal at the muscles of the spine or whatever. These calculations, you really just like.
Right, it can't possibly be. I mean, I'm telling you, you hold those tissues and you feel them. They can't do that. They just can't do that.
And I think that this is really an interesting part here because you see, that's where your experience as the orthopedic surgeon really kicks in very importantly because look, if we talk about even the sort of the mild manual kinesiologic and all these professions starting from the physical therapists and kind of extending all the way to the body workers, what happens is that you don't experience the tissues firsthand, so you might be unhappy with, so therefore those numbers, the way that they're presented in the textbooks, they're actually supposed to encourage fascination, like, wow, look at that, this thing is actually, don't you realize that this thing is able to get 900 pounds of whatever force per square, and then per square whatever inch, or any other of those big numbers, and then you look at those and say, wow, this is impressive.
Yeah.
But for you, that was actually the main point that really screamed.
Yeah. You put one of these in the hip and you feel this thing weighs, is heavy and it's solid, and I use it for crab crackers, to crack crab. But this is a big, heavy, solid kind of thing that we manufacture, and it's real. And you look at bone that this is supposed to be replacing, and it's nothing like this. Nothing like this. It's soft, and if you whacked it like this, it would crack, not the crab. And you say, well, that's kind of craziness to think that this is what it's like.
All right. So many good and great little tidbits in there, huh? Let's see. I guess anybody who wants to can unmute. We're a fairly small group. And you can just wave or unmute or speak up if you have a comment or question.
Oh, no, that's not the head.
Yeah, I have a question. Steve, when in this history you haven't gotten yet to meeting learning about Bucky's work, or what year did you first?
Steve Schofferman, just want you to know your camera's still off. You can
Yep.
you can keep it off. That's fine.
Yeah, no, I hadn't gotten to Bucky yet. I didn't get to Bucky until after I discovered the tower, which is in 75. Then I started looking into who built it and why. And that actually took a while to get to Buckminster Fuller, because I got to Snelson, and then I corresponded with him a bit, and we went back and forth. And I finally got to Bucky, but I didn't start reading Bucky's work. I started reading books about Bucky first, because Bucky's stuff was just overwhelming for me at the time. So I started and I couldn't understand it. Then I started reading some books about him, and that included some of that. And actually, an architecture book by Peter Pierce, I think his name is, if I remember correctly. Right.
I think we covered it at some point. We covered it, like
We did.
quite a few
Yeah,
episodes later. Yeah.
Yeah, that's where I got into, Bucky then.
Thank you.
Pedro, did you have a question, or are you just jumping on camera? And for those of you who don't know, Carol, Pedro, Bruna, Eileen was here earlier. They're all going to be here next week.
Well, it sounds like, people think when they hear the story or, me talk about the tensegrity, think that I was searching for tensegrity my whole life and doing research in the field. And it was all serendipity. I just kept getting stuck into another problem and said, well, I got to figure out how to get out of it. And then, I would work on that. And frankly, it's still happening. I still keep going back and say, well, it doesn't work. I have to figure out another way. So, I've now given up on muscles as doing anything. And I've rethought completely how muscles work. But we still talk about muscles doing things when they don't do anything, at least not what we think they do. So it's still happening to me, even though, it's part of this process of just getting a new paradigm. And then once you start working from that paradigm, you have to start giving up everything else. And that's a real process. And it takes years. So you have to understand that some of the things that we talk about here, you may just peripherally get, but it'll actually take you years to get to fully understanding it. Because getting rid of this whole concept of what muscles do and how they do it is very difficult. And it takes a long, because we've all been brought up with this whole muscle model. And it's a law. I'm not there yet either. I'm just working my way into it. But it's all part of the same thing. It's once I got a new paradigm, you just got to keep moving from there.
Yeah, well, I think that it makes sense to highlight that kind of few takes on that, right? Is that the first, because, well, we all kind of without exception, including biomechanists, right? So you see, we all kind of in the process of the lifelong learning. So, and that's why, besides of those kind of hundreds of increments of learning that it kind of takes, and which kind of occurs every year, there are some really critical big ones which are establishing those bifurcations. And I think that that's what I wanted to highlight, that the central point from which Steve approached it was like the body has to have the inherent sort of automatic built-in stability. So that is really the centerpiece of the whole thing, where the current model, which is inherently unstable and kind of falls apart and then requires certain external agent, for the bones, it requires the external agents of the muscles. For the muscles, it requires the external agents of the sort of signals. For the signals, it requires the external agent of the brain. It's a kind of just an overlap of the external agents which just keep helping each other but in order to handle this continuous tendency for the things to fall apart. And that's where Steve came up with a much stronger kind of this core point. This thing has to be simply stable, right? So you see, without all this kind of superstructures, super kind of reservations, super extras built on top. And I think that is really the essence which separates it. So he was taking it from that angle as opposed, and then was looking, okay, what would be the available kind of architectural, mathematical, physical, and so on types of frameworks which would fit this definition better than the liver model, right? So that is really one key aspect, and that's why the conversation on trusses, right? And I mean, I think somewhere we even spelled it TRUSS, because the way Steve makes it into his kind of Bronx accent, it's really like it's really impossible to understand what that is, a TRUSS, right? So you see,
Right.
so that is really a first thing. And again, it's not like fascination with triangulation as such, but it's the fact is, okay, we have to find something which kind of fits the idea, fits the interpretation of the stability, and kind of currently we talk about the super stability as to reinforce it, right? So I think that's one really big idea which I think it's really essential to take at it.
And
And
it often gets overlooked. This is why I tell people they need to build triangles and tetrahedrons. Can we take Steve
Yeah.
Schafferman's question, or did you want to say something else?
Early in your little response or rant there, Leonid, you repeatedly used the phrase external agents. And I think that's really a key. And Steve's breakthrough, and this was the same breakthrough from Moshe Feldenkrais, is understanding that everything has to be internally self-organizing. And
exactly,
that properties emerge from within at every level.
That's it. But you're absolutely right, because this is again becoming more and more kind of obvious in the recent years. So it's through the network sciences and so on. So what are the true costs of the external agents in terms of kind of keeping things organized, and in terms of what kind of vulnerabilities the system has if it relies on the external agents, right? But on the other hand, of course, the allure of this, the attraction of easy calculations is so strong that an engineering mind cannot pass it, because unless an engineer arrives to numbers, he has nothing. So that's why that is another very, very important thing to understand, the role of numbers in their worldview. So that is a very critical thing, and that's why I maybe, you see, like the last point from this particular conversation, from this particular episode, I also wanted to highlight a bit, because you see, it's a very unique position that Steve has been occupying as a person with their orthopedic background and a long orthopedic practice, who have been then switching more and more and more into manual practices, right? So you see, kind of occupying this place, because the natural question is, why it's not the manual practitioners who question their biomechanical model in first place? Why we have so few of the manual practitioners really kind of strongly questioning the biomechanical model? And I think the answer is in part with what we discussed even before the party, right? So that the practitioners who are manual, they don't have everyday experience of the live tissues. All this conversation about the egg white density, about the mushy stuff, about that we are made out of, like snot and so on. So this is, for us, it's still, if we are not there, right, it's still abstracts. And then basically it's this abstracts running versus, this calculations. And that's what I was trying to express there, that if you don't have the everyday experience of, and the opportunity to to poke with the backend of your scalpel into the mushy egg white of the cartilage, you don't have this kind of super strong, like, no, this thing cannot, by any means, this thing cannot hold 900 pounds of pressure, like, this is ridiculous, right? So you see, you have to have this, and if you don't have it, it's like, oh, okay, it's weird, but maybe, because also then you flip it, and the only dissections that you have done are dissections on the dead bodies, and on the dead bodies, like those cartilages, they look strong, and you say, well, maybe, you see, this experiential huge distance between the live cartilages, live bones, and the dead ones is the one which really makes a huge difference there. So I think that kind of combination of the serendipities and kind of overlaps of the experiences and practices is a very, very interesting thing, that kind of very unique window through which the whole thing kind of went. So I'm sorry for the long rant.
No, that's good. And for those of you who are new and don't know Steve Schafferman, he's the author of Awareness Heals and some other books, and worked very closely with Moshe Feldenkrais. Bob,
we've got a question from Bob, so his arm is raised.
Bob and Pedro. So Bob, you're first.
Thanks. I found Steve's history, fascinating, but what I found also interesting was his perspective as an athlete. I mean, being a lifelong athlete and a coach myself, is like, when I wasn't a wrestler, basketball player, soccer, but when you get your hands on people and you see how quickly they can move and turn and spin, the stacking concept just doesn't, make a lot of sense. And the comment that I made during the lecture about not knowing the difference or the importance of a clinical exam and not knowing the difference between pathology and dysfunction is like, when you watch people move and you're used to watching people move, you can see clearly that there are some limitations of motion that make a whole lot more sense, that could be explaining the pain than the findings of the still picture, whether it be the X-ray or the MRI. But I thought the perspective as an athlete really hit home for me.
Yeah, I love that part. Thanks,
I mean, I was, you see, look, I tell you how I got it, right? So you see, while I was flipping through the thing, we didn't show it, but that's why I popped into, one of the leaflets, the wrestling championships from 1952 and so on. So I say, I kind of pulled it, flipped it, and found, Steve wearing, what's the name of this, three-quart or whatever, this kind of wrestling thing, and posing there. So
this is Leonid nosing around in Steve's library.
yeah, that's it, and that's it. That's I really kind of got it from there, and really wanted to get this perspective into it because I think it's really absolutely you're absolutely right, Bob, that this is quintessential, right? It adds to this perception of, like what are we trying to understand, right?
That's great. Hey, Pedro, you're next.
Thank you, Susan. I'm also excited about next week. You put in comments. First, it was just very quickly to say thank you to everyone who's organizing this. I knew Stephen has always talks about his wrestling experience, but I never actually understood how this was important. And so now it was much more clear. Thank you to everyone who organized this. And my question is, when was, Stephen, the first time you realized like the consistency of the living tissues that you often talks about?
Well, as a surgeon, your first experience, you do anatomy, but your first experience as surgery is completely different. Once you're in there touching tissues, everything changes. And all the stuff that you learned in anatomy, you say, oh my God, it's not like that at all. And then you start appreciating tissues. And, like people always talk about, well, nobody talked about fascia until now. Well, surgeons always knew that we only sewed fascia, that there was nothing there strong enough. The parenchyma of whatever we were sewing doesn't hold anything. You have to get the fascia to sew. So as a surgeon, but particularly in orthopedics, you're always sewing fascia. You ignore the muscle. Muscle is mush. You can't put a needle through it and hold it together. You have to sew fascia. So fascia has always been part of our concept, but it's never been separate from the muscle or separate from the bone. It's always been part of it. So this whole thing of fascia, you begin to understand it. And when you're doing knee surgery, you start poking at these things and you have a little, it's a dental probe, actually, with about a 5 millimeter point on the end of it. And you go like this along the cartilage and indent into the cartilage with it, because you're looking for pieces that are going to flake off, for instance. So you indent it, and you have to realize that you're sticking this in. Someplace or other, I have just came up with this stress strain curves of bone, muscle and fascia. They don't separate it, and cartilage. And cartilage has the density, the stress strain curve of mashed potatoes. I mean, it's that soft. The damn stuff is crazy to even think that it does anything if you look at the math of it. And even those guys who are looking at the math of it ignore the math and then say, we can bear weight on this structure. It's insanity. They just, they dissociate things, not me. They dissociate this concept and they completely separate, and again, the biomechanics people have no, they don't deal with tissues except dead tissues, or in a clinical or an experimental situation where they're guessing what's going on inside, because essentially the body is a black box and they only see what they put in and what they put out, and they're figuring out all these things going on inside, but they really have no idea.
And Steve, can I get clarification on, you said you learn about the body in anatomy and then you get into surgery and you see that it's completely different. And when you say you learn about the body in anatomy, you mean in dissection, working with dead stuff. They prepare you that way, and then they send you into a living body and you realize you're in completely different territory. I don't want to put words in your mouth, but is that
right? Anatomy is cutting things up, and separate. So, I mean, there's a big push for everybody to take a anatomy dissection. Frankly, I think it's a waste of time. I mean, and all knowledge is good, and you learn things, and you may get a point or two. But if you want to spend your money, there are better ways of spending your money. That's my, and I've done anatomy. I mean, I'm not, I'm just telling you from the standpoint of clinical application of what you're doing and what you learn in anatomy. It's really not very, it doesn't, you don't get your bang for the buck.
Thank you. Carol.
Well, I too want to say thank you, Leonid and Steve. That it's so nice to go back in time because I'm not that far behind Steve in my history. And I had grants, of course, and grays, and I realized too that it was the experiencing through my hands that had me asking a different kind of question. And then I discovered Barnes in '89 and used those principles of sustain, pressure, gentle pressure, and then elongation, and felt things moving under my hands and knew that there was something in there that I was experiencing, not just with my proprioceptors and mechanoreceptors, but there was a sense in which I was feeling the whole, the web responding. And then when I was practicing regularly in Miami and treating patients, I became known as the person that a couple of general practitioners and rehab specialists would send their low back pain patients to me first before surgery, and also their carpal tunnel patients. Because there was something that I could do when I was doing this manual therapy that might relieve them from having to have surgery, just like Steve found out. But where the logic didn't sink was that the orthopedist knew that thoracolumbar fascia was really thick, and there was nothing that pressure could do. And Schleip has an article about this, and David Lazondak often talks about this when the tissue's really, really thick, and there's nothing that we're doing with our hands that's making a difference. That's left brain thinking. And it doesn't take into account other ways of thinking. And then I thought, Steve was not using left brain thinking when he was kinesiologically and interoceptively interpreting the feel of the movement before it happened in his adversary in wrestling. There's another way of knowing here. There's another way. It's not logical. It's not based on solid state physics, and it's not based on A plus B equals C. It has to do with web behavior. It has to do with systems behavior. It has to do with mechanotransduction, electron flow. It has to do with intuition. It has to do with sensing from the fascia that's available to us as manual therapists that doesn't make any sense to people who have been educated in a left brain mechanistic way. So they're not going to be apt to change their paradigm until they can feel it themselves. Now, there are lots of ways to feel it. You can go and take a course and learn these principles and practice them. Or better yet, you can go be treated. And that's why I always offered to treat these folks free, so that I could explain to them from my perspective and from the YouTube video of strolling under the skin and some of the consciousness and the energy flow work of Ashman especially, to get them to open their minds to consider that a triangle might be more stable than a cube. And that's all we're really asking. Just open your mind a little bit and feel, and let go of that left brain logic and feel and experience. And that's what I heard Steve saying all the way through. But Steve experienced, as I said in the chat, some of that patronizing, go stick to your own wheelhouse because you're out of your league here. And the sad part is it's the patients that suffer. That's all I really wanted to say. So thanks very much.
Great. My husband and I were out working in the yard the other day, and he said, if people want to understand biotensegrity, they just need to get out and play in their gardens. I mean, because then you're feeling when you try to pull a weed or pull on a vine, different plants have different strategies. some let go, you know, poison ivy, the top part always just lets go so that the root can stay underneath. And, you know, if you can get to that root, there's a strong tug you're going to have to go, or you gently have to follow it so that it doesn't break, you know. Anyway, so I just think a lot, there's a lot we can learn about living things just by interacting with them through our fingers. And it doesn't even have to be another human.
When I was in the course teaching manual therapy in Michigan State with some group of osteopaths, actually, the first lesson in the course was layer palpation. And what we do is just feel the arm and go through the skin and, you know, the hair on the skin and the front of the arm and the back of the arm and the different textures, and then go layer by layer through till you hit the bone and then feel the springiness that's in the bone. And that's what I'm saying you miss in dead anatomy. You can't do that in dead anatomy. And that's why when you people learn layer palpation, you actually are learning more than most of the anatomists are learning, because they don't get that kind of feeling. You can't get it in the dead body. So you can actually go layer by layer and feel these things. And just learning that was the key to, as far as I'm concerned, manual medicine, is understanding that and being able to feel those layers. And as I said, that's my argument with anatomy courses, is that unless you are looking for something and have this experience beforehand, you're not going to learn a lot in anatomy that you can't learn in a book.
I'm gonna share my screen and just share the picture that Leonid just sent to us. There was a great exhibit at the National Botanic Garden downtown a few years back, and you went in and all the plants, all the different grasses were way up at the top, and the main display were all the root systems. And it's just incredible how we look at something and we're not seeing the whole thing.
Yeah, but I mean, Susan, you see, that's the thing, is that you see our entire kind of societal structure, if we put it this way, right, is built on competition and on performance. So how much performance are we able to squeeze and mine out of some natural processes, right? And I really love that picture because it shows, you know, like, what do we get out of the agriculture, right? So you see, we get what is the minimal kind of root we can have to get the maximum crop, even if it requires all sort of artificial external agents, you know, like changing seeds, putting fertilizers, putting this, putting that, you know, like kind of putting into a mega, creating a mega fragile and mega protected environment just to optimize the crop, which actually also ends up being of low quality as well, right? And this is, yeah, and this is again when we get into their thing, what is a functional anatomy, right? So you see, functional anatomy is a performance extraction out of the human body, right? And that's what we have to remember, you know. So what is the biomechanics? Biomechanics is a service industry, you know. It's a service which helps extracting, you know, maximum crop, you know, yield out of the biological things, right? You know, out of the biological processes. That's what it is designed for, right? And again, Steve, hearing Steve's talk is, you know, a kind of whole reminiscence of how the things were and so on. It's been very, very instrumental and very, very like interesting as well, because it just shows that things didn't have to be that way, right? So you see, around that entry of biomechanics, they had the opportunity, instead of servicing this kind of old dogmas, right, they had the opportunity to challenge them. But servicing them and kind of taking this mantra of engineering crop optimization was kind of the, did it the quicker and more rewarding or whatever, and at the same time convert it into a productive, part of the all of this prosthetic surgeries and so on, right? Because this is what biomechanics actually services, right? It services prosthetics. And this is what we have to keep in mind, right? So you see, and but I really love that picture, right? So you see that just shows that but reminds us that everything that we have is performance optimized, right? So, and the word performance dominates and kind of permeates every conversation that we have now. Whilst performance is about this, right? So you see, it's agricultural crop which cannot act with, which is not inherent, which requires this kind of layer upon layer of the external agents, and which makes the whole thing super fragile.
It reminds me also of people are, doing their sports workouts as if they were multi-million-dollar athletes. So I understand if, there's an athlete whose career, multi-million-dollar career is dependent upon them operating at a certain level. But
this is a person who is mining his body to get their outcome crop, right? So you see, to get the performance crop, which they sell, but they sell it, it's a deal, right? So you see, they sell it for, the idea that they sell it, I don't know, for 10 years of professional career, they don't need to do anything afterwards, and they can spend the rest of their life recovering, right? So, but this is being sold as a health, which is
exactly.
So, which is again, and actually the title of this picture was annual crops versus perennial crops. So not just agriculture, nature, right? But annual versus perennial. So that those are that, and if you ask about health-wise or whatever, what do you want? Do you want annual health or do you want perennial health, right? So you see, as if we had, life renewal policy every year on the 1st of January, right? So this is really crazy.
So let's go to Mike next. And for those of you who aren't part of Chris and Gwen's embodied biotensegrity group, which I highly recommend, Mike did a fabulous presentation on Wednesday showing us his kind of journey as a puppeteer, or I don't know what you call it, Mike, you'll correct me, and how tensegrity relates to that. So over to you, Mike.
You should have called him a puppet master, like a master of puppets.
Oh, I have a whole spiel about how much I hate the term puppet master.
I mean, so you don't open it with Metallica, right? No, so.
Oh, no, definitely Metallica or ideally Iron Maiden, but.
Oh, wow, this is great. So that's okay. So you can count on me for that support. So.
Oh, right, that's great. Yeah, thanks, Stephen and Leonid for making all of this happen for this conversation. I think as a puppeteer, I'm very interested in sort of like in bridging the gap in sort of like the public imagination of shifting away from thanks Stephen for writing this down, Steve Schafferman, moving away from mechanistic, materialist, reductionist towards the holistic, functional, and experientialist, which is just such a fabulous, succinct way of doing it. I think that like puppetry benefits from tensegrity, and that like it's this whole moving. I mean, you guys get it. Just imagine a puppet that moves on, pin joints, or one that moves on, on tensegrity joints, frictionless. It's great. Just a little bit of background. but my question is, in terms of the weeds and the crops, or the in terms of like agriculture, we live in a hyper capitalist world that is excited about extracting value, and that is the framework that people's minds are already in. And I'm wondering if there is, other than things like manual therapy, which does not scale, and it's like that is part of why it is so important, because it's so not even just like individual, it is like in that exact moment, like it is engaging in the process. Are there, and I think of like Snelson's Needle Tower and like sort of like these big sculptural things that are made to sort of like capture the imagination. I'm wondering if folks have any thoughts on how does one help make the transition from a framework that people are already sort of baked into. And I realize this is sort of a big question, but how, right, other than books, other than things where somebody has to really seek the thing and like be in the room with it. I'm wondering if folks have any thoughts on sort of how we can pave the way towards a broader understanding.
I guess this kind of thing deserves a separate Biotensegrity party, right? So you see where we can invite people to get these conversations, right? Because, like, for example, you see, we are all inevitably narrowed by our kind of professions and experiences, right? So you see, we have to work and kind of earn a living, right? Which sort of narrows the scope. And that's why I think it's very interesting to meet, like, excuse me, but I would never even like, beyond the master of puppets, I would never think there is such a, like, specialty and the dimension as a puppeteer, to say so, right? So you see, but there is definitely a dimension there, right? So and this is where we can broaden those perspectives and kind of, I think that's sometimes it's just a question. It could be completely something unrelated that could catch, a public imagination and actually create a certain flip. So I think that it's this diversity that could be really a big, a big driver of this.
And I would say that the current way of looking at things is about extracting short-term value.
Yeah,
Because
annual crop.
Talking about long-term value, you have a completely different perspective. And in terms of it's kind of relating to what we were saying about the athletes that are professional. Most of us are looking for the long term, the sustainability. What is going to be sustainable over time.
So I think that that at some point we really need to organize a conversation on that, because indeed, you see, it's not just the theoretical kind of benefit, but it's absolutely true that the whole idea is that self-stabilization is what carries natural organisms for much longer than what they would have done if they were organized upon the immediate short-term value extraction. The annual crop dies. So, and like, it's just the specific way of interpreting value. And I think that it's actually happening one way or another, right? So you see, if you look at the undercurrents, there are undercurrents, on the one hand, we have all this kind of hypes and super short videos and super short whatever clips and whatever, all this attention dragging and clickbaiting and so on. But on the other hand, we have the slow movements and the stoic movements and like also the awareness and the bodily awareness and the mind-body awareness. So the tendencies, they are there, but I think that one of the bigger parts there is actually to understand that our entire quest for whatever sustainable future of Earth is futile unless we change our perspective on anatomy. Because basically we discuss everything like, okay, sustainable climate, sustainable life, sustainable whatever. And what's at the heart? We have the most simplistic, mechanistic kind of, outrageously performance-oriented mechano model from 500 years ago,
Mm-hmm.
So for me, there are plenty of great tendencies and great realizations in social sciences, complexity sciences and so on. But the thing is that everybody gets paralyzed the moment they, like this, it's literally people stop thinking and become dumb as idiots the moment they get to the bodies. Like, just, you see most brilliant people, like, I follow a lot of physics and all this kind of complexity, machine learning, and all sorts of conversation. And they say all these things, let's say, oh, Bayesian science lands, Bayesian landscapes a priori, and then when it comes, they start bringing examples about the body. Well, for example, the data set of their blood pressure measurements. And I say, guys, this is all you can say? It's just people get completely, people from the clever sciences, they get completely dumb and they take anatomy as the reality. And you see, this is, for me, this is a vortex, this is a gaping hole in the entire kind of, collective mindset of humanity. We have a, we don't realize that we have such a crap model of ourselves. How can we possibly change the world around us, the external universe, when our internal and kind of body-to-body representation is so bad? That's why for me, this is actually, it's a part of the bigger thing, and that's really why, like, I think it's not just a little thing for the therapists, right? So it's like to find a better model for the manual therapists, for whatever fitness practitioner, physical therapist, and so on. I think it's instrumental for the entire kind of science and psyche and mentality construct, because we cannot heal our kind of planetary thing and so on until we kind of look at the mirror and say, gee, it's a 500-year-old crap model which we're still kind of dressing up, with all sorts of modern vignettes, but essentially it's a rotten model.
Speaking of models, I'm going to jump in. Bob, if you don't mind waiting just another minute, hold on a second. I'm going to spotlight Mike, who has a great treat. Do you mind? Thanks, Mike.
Oh, no, yeah. So here we have a couple of the OG Alberts.
Wow.
That I'm currently working with Dorothea to reconstruct, and it's very really. Yeah, this was one of the ones that Tom Flemons made, and it was stored in tension, and it's so wildly loose. So we're trying to get it back to life.
Wow.
So have you been coming up to any questions or problems? Steve, I know you helped Tom develop a lot of these models.
Well,
Susan, maybe just a short interruption. Actually, before our numbers dwindle, I want to say that Jaap van der Wal has his birthday today, so we should wave and send him our collective kind of greetings, and also whoever we can remember and just drop him a line on Facebook or whatever. That would be, I think, always a good thing.
Let's do our closing toast early, but we'll keep going and say happy birthday, Jaap.
Well, we'll say happy birthday to him. That's true. So one of the great, conceptualists of our time. Thank you.
Okay, great. Good interruption. Steve, you were going to say?
I don't remember. Oh, about Tom. Yeah, actually, I was I'd ask him a question and challenge him, and he would make the model. So I really didn't have any input in his model making, except to give him what I thought I needed to illustrate something, and then he would do it. He would sort of pick my brain from that, and then we would argue about lots of things around it. But like we fought forever about the knee. We never got that straight, getting a model for it. But as I said, he was one. I didn't build his. He was building models, tensegrity models before I met him. So he had a head start on that, and he had this technique that he used where he can. I talked to him, and while we were talking, he would build a model that would illustrate what we were talking about. So it was that kind of loser. I just want to mention, we got into the serendipity thing. You have to understand that I was also a serendipity wrestler. I didn't wrestle in high school. I never meant to be a wrestler. I just went to City College in New York, which is a subway school. You go there by subway and you go home. And I wanted to stay around the university, and there was Joe Sapura, the wrestling coach, had an open gym, and anybody could come and learn to wrestle. So I did, and I turned out to be okay in it. And I ended up at one point a captain of the wrestling team, but I had no idea what I was doing. And I certainly was not in any class of the wrestlers who were spending, 6 hours a day wrestling, and twice on Saturday and Sunday. I go in there 3 hours, twice a week, and that was it. So that was just luck too. This whole thing was serendipity.
That's great. Hey, Bob, thanks for waiting. Go ahead.
Oh, no problem. Just a quick response to Mike and capture some other things saying is like, while I agree with Leonid on a macro level that changing people conceptually is important, but probably very hard. I mean, Mike, my experience has been is seeing is believing. And a lot of people say is, why are you getting people better that I can't? And then they're willing to listen to the conceptual theories, and you can talk about things, and then they're more willing to listen. But before that, maybe not.
Yeah, absolutely. You see, it's proof by demonstration on the one hand, right? So you see, this is one thing. But the unfortunate part, right, is that our profession is not very scalable in that sense, right? So, but on the other hand, we still have to remember that one of the key drivers of science, even today, it's still the beauty. So people enter and choose the way of science for the beauty and for the search for truth. Of course, you do it as a kind of idealistic teenager, and the world of kind of Hirsch indexes and whatever else is trying to kind of mold you into this. But still, inside every researcher, there is still a quest for truth and the quest for beauty, right? So, and that's what I'm less idealistic now than I was, 20 years ago or 30 years ago, but I still find the fascination in the beauty. So, and I still believe in it.
All right.
Well, thanks, Bob and Leonid. That's great.
Bruna's showing us a beauty right there on her lap.
Yes.
Mm-hmm.
Can we give a wave?
A dinosaur.
Perfect. Dinosaur is in a later episode.
Yeah, that will be later. Yes.
All
Okay,
right.
so shall we
Close it up? I think so. Thanks everyone for coming. This is really wonderful. We're going to have another
sooner than soon enough, right?
Yeah, so we're going to have next week. We've got a great team of physiotherapists that have been meeting for I don't know, over a year. And Carol's already gone, but Camilla or Pedro, do you want to tell us a little about next week? Maybe not, maybe yes. Anyway, we're going to have a team of physios that have been working together and exploring what biotensegrity has to do with their work. And a lot of them started meeting when they were taking a class based on my book through embodied biotensegrity. So it's, and Bruna,
Wow.
Bruna's part of that group, right? Yeah. Bruna, or does anybody want to talk about it, or just we'll wait till next week?
Well, let's wait. Just your course was almost like 3 years ago, I think. So we are meeting since then.
Maybe 2 years ago.
2 years ago. Okay.
Yeah.
Anyway, it was longer. And we started to meet based on the idea that I think Mariana was teaching a workshop, and we were thinking how to teach anatomy and how to teach movement from the clean slate when there is not this biomechanics background and when there is not this cutting parts and pieces background. So that was our main question from which we started to evolve further on.
Great.
And we're all very, very geeky. So we kept on meeting every week because of that.
Wow, that's impressive.
And then,
So,
and then 2 weeks.
You
from
should have
today-
transcribed the recordings, right? So
Yeah, well, and then 2 weeks from today, we're going to have episode 3. So stay tuned. If you're watching from YouTube and you don't, if you're not already on the Biotensegrity Archive email list, we recommend you go to biotensegrityarchive.org and join the list. And Graham, any other thoughts for today?
Sorry, I got distracted with something.
That's okay. We're just signing off. So I just am checking in.
No,
And
I've enjoyed watching it again. It's always useful to see and hear the conversation.
yeah, because you were the cameraman, of course, for all of
Wow.
these.
Well, a lot more than that, right? So you see, that's because you see, we only film small part of the conversations, right? So you see which happened during the entire day. So,
All
just-
right. Well, thanks everyone. And
Thank
we'll
you
say goodbye.
all. I don't know how you tolerate listening to me for an hour, but that's beside the point.
that's